Okay, so first I want to give a short historical perspective, but I think that's mostly been covered by Bill Swan, so I won't dwell on that. Then to discuss the kinds of policies in the healthcare sector that can be informed by economic analysis. And then I'm going to focus on one set of policies that are to do with the use of economic evaluation as part of a broader process of health technology assessment, and within that say something about the evidence on whether using economics in this process has had any impact. And I'm going to use the example of drug pricing and reimbursement as my example in studying the impact of the use of economic evaluation. So next slide, please. So, as Bill said, we saw health economics emerging as a subdiscipline in around the mid-1960s, and at that time economics departments began to issue postgraduate degrees or PhDs of people that had studied health as a topic. So, for example, one of the first ones was a PhD by Martin Feldstein on hospital efficiency at the University of Oxford in England. The first master's course was established in York in 1979, but several ministries of health have employed, it says here, healthy economists. I think they probably mostly are healthy, but health economists for a number of years. And for example, I think the Ministry of Health in the United Kingdom employed its first health economist in 1969 and has had quite a large group of economists working there for several years. And of course international agencies such as the World Health Organization and the World Bank have used health economics in policy development, mostly of course in public health areas such as immunization, but also more broadly within the healthcare system. Next slide, please. So if we look at the areas where health economics has been applied, I think we can divide this into two groups. Policies for the healthcare system in general, and then policies for healthcare interventions. Now, if we take the first area of policies for healthcare systems, the kinds of things that economic analysis has been applied to are the development of health insurance systems and, more broadly, different ways of financing healthcare, studying the performance of healthcare systems, either in the aggregate or in terms of certain components, such as the hospital sector, basically trying to understand what we get out of those services in relation to the resources that go into them. And also there's quite a lot of work on devising payment systems and incentives, both for healthcare professionals and also hospitals and other healthcare institutions. I think it's probably true to say that most of the work of economists, certainly up until about 10 years ago, was applied in those kinds of areas, and there's a very large literature. I'm not going to say much about it now because it's not my main expertise, but just to say that if you take the decision that you've made to establish a single payer system for healthcare, I think there is quite a strong body of international evidence that would be supportive of that policy, that generally speaking it's a good idea. So let me talk about the area that I know more about, which is policies for healthcare interventions and the application of economic analysis within those. And of course, certainly in lower middle income countries, there's been a lot of work on public health in developing screening and immunization programs, and certainly the World Health Organization has been very active in that. In higher income countries and increasingly several middle income countries, the growth area has been in health technology assessment of drugs, devices and other health technologies. And more broadly, developing clinical practice guidelines with an economics component in them. We have an agency in the United Kingdom called the National Institute for Health and Care Excellence, which goes under the acronym NICE, and they have several programs. One on technology assessment, which I'll talk more about in a minute, but also they do have a program on developing clinical practice guidelines with a strong economic component alongside the consideration of the clinical evidence. And they also have programs in areas like public health and social care, as well as more traditional health technology assessment. Next slide, please. So I wanted to say more about the use of economic evaluation within health technology assessment. Now, health technology assessment itself has been practiced since the 1980s, but the big change from the early 1990s was that health technology assessment has been more closely linked to reimbursement decisions. That is, decisions about what kinds of treatments and services we actually pay for in the healthcare system. And along with that change, there was an increase in the economic component of health technology assessment. So, if you like, what happened was that in the early days of health technology assessment, they would just produce a report that would be published and distributed, but there was no clear link to the decision-making process. People could either accept the report or not accept it. There were no obvious consequences of doing a health technology assessment. But from the early 1990s, there became this link whereby doing the study was becoming hardwired into the decision-making process in healthcare. And that sounds like a small step, but believe me, it took a lot of time and effort to get that far, and I'll show you in a minute that to go down that path is not without its difficulties. So now that economic evaluation is included in health technology assessment, the kinds of questions that come up are, well, is there any evidence that adding the economic component has had a positive impact, and how would we judge that? And are there any examples of successful practices within health technology assessment, including an economic component? So I want to say a little bit more about that. Next slide, please. So the role of health economics in HTA really started in the early 1990s when in 1991 Australia passed a rule to say that they would request economic evaluations as part of the process for reimbursing pharmaceuticals. That is in their national formulary called the Pharmaceutical Benefits Schedule. Now, the interesting thing about that is that why focus on pharmaceuticals? Because in a high-income country, pharmaceuticals would be between 10 and 15% of healthcare expenditure, probably slightly higher in some middle-income countries. But there's no reason to focus on one sector, and the countries that really take health technology assessment seriously actually look at all kinds of healthcare interventions, whether they're pharmaceuticals, medical devices, configuration of services for healthcare. So I think it is important to recognise that health technology assessment is not something you just apply to a few high expenditure items. It's something which really should be a tradition in the healthcare system more generally. I think one of the reasons several countries started with pharmaceuticals was that, at least for pharmaceuticals, there is already a process in many countries for making a decision about which drugs are included on the national or local formularies, whereas we don't have the same kind of decision-making process, for example, for adopting a new surgical procedure. We adopt new surgical procedures just because surgeons feel they should do them. There isn't really, in most countries at least, a formal process for deciding which procedures you would use. Although countries that do have a health insurance package and a stated list of benefits could, in principle, apply HTA to that more generally. So the policy to require economic evaluation for the process of reimbursing pharmaceuticals then spread quite quickly, became mandatory in Australia in 1993, and then it was fairly quickly followed in New Zealand and several Canadian provinces. And in Europe, I think we're a little bit late to the table. NICE in the United Kingdom was only established in 1999, but now I would estimate that about half of the countries in the European Union request economic evaluations to some extent. In some countries it's basically every new pharmaceutical requires an economic evaluation, but in the majority of countries it's used on a selective basis, and priorities are set for which drugs they require an evaluation on. Not every drug is looked at in several of the countries. And now this has spread to other parts of the world. In the United States, the formal consideration of economics is not strictly allowed within Medicare or Medicaid, the public parts of the healthcare system, but several of the private insurers now are beginning to use economic evaluation. And we now see several countries in Latin America and Asia either using economic evaluation or expressing an interest in receiving economic studies. So in this part of the world, apart from Australia and New Zealand, we would normally think of Korea, Taiwan and Thailand as countries that have at least made the first few steps along this road to using economic evaluation. Next slide, please. So how would we know whether this had any impact at all? Well, the first thing to recognise is that before economic evaluation came along, there were different policies for handling the approval of new drugs. That is, approval for payment, not approval for market access, because the licensing process has always been kept separate. But some countries had little or no controls on payment for drugs. Germany and the United Kingdom, we essentially paid for all new drugs as long as they had a license, and there was no price controls. Some countries used to have price controls, so France would be an example of a country that essentially paid for every drug but had price controls. And then some countries, even before economics, had reimbursement controls. So Australia and Canada would be an example of countries that did have controls about which drugs they paid for, but weren't formally using economic evaluation. And of course, many countries also had local controls, such as hospital formularies. Next slide, please. So, how would we judge whether there'd been any impact of using economic evaluation? Well, we can think of this in several ways. One way we can think of it is, were there changes in the processes followed during drug reimbursement? And then we could perhaps look at changes in the outcomes, both in terms of the decisions that were made and also in terms of whether that affected the provision of healthcare in the country concerned. So if we look first at the processes, there is some evidence that introducing economic methods has been a bit of a challenge, both to manufacturers and to ministries, and I'll say a bit more about that in a minute. There is some evidence that the methods for economic evaluation of drugs have actually spread a little bit more widely than just looking at the drug submission process. We've also learned that the level of scrutiny of reviewing the studies does make a difference, and I'll show you something about that in a minute. And also, we know there's a choice between looking at several drugs at the same time or looking at each drug individually. The second approach being a little bit more similar to the licensing process. And some countries have oscillated between doing one of those or the other. In the United Kingdom, NICE started with what it called multiple technology appraisals, where it would look at several drugs within the same class or same therapeutic area together, but now has moved to more of a process where they look at every drug individually, although of course in looking at it they do compare it with other drugs, normally comparing the new drug with the current standard of care. Next slide, please. Now, just a little bit of evidence on some of those things. About some of the challenges, there was a study in Australia that said that studying the first 10 years of operation of the scheme there were 326 studies, but in those studies they identified 249 methodological problems. Almost one problem per study. So that suggests that people were initially at least having difficulties in doing the studies to the right kind of standard. And in British Columbia in Canada there was a study that said that a majority of the submissions that came in from companies did not comply with the guidelines that the province had set out. And there's also some observations from the Ontario committee that said that despite all this growing interest in economics, the clinical factors are still the most important. And I think that's probably still true now, that we can talk as much as we want about the need for cost-effectiveness studies, but we also need to have the basic clinical data to do the studies on. So obviously the need for good clinical data is still the most important thing, even in countries that extensively use economic evaluation. Next slide, please. This is the paper that said that looking at Canadian economic evaluations, the guidelines that had been established by the Canadian Agency for Drugs and Technologies in Health were being widely followed in areas beyond just pharmaceuticals. Next slide, please. Other things we could say about changes in process that we could link to economics. So one thing is that since we started using economic evaluation, there's been a growth in what are known as risk-sharing schemes. And these are schemes whereby the ministry or health insurance scheme will agree to allow a new drug for reimbursement, but would then want some more evidence to be gathered as part of the deal for accepting the drug. There's also been a growth in the use of pricing based on value. Within the companies themselves, clinical development programs have been refocused to the delivery of added clinical value. And there is this use of economic evaluation outside of these formal processes. Next slide, please. I've been told to speed up. There's also other things that have happened which we could say are partially attributable to economics. There's been a recognition for the need for more relevant endpoints in clinical trials. There's been consideration of different ways of synthesizing clinical evidence. There's been a recognition that clinical and cost effectiveness varies by different subgroups of the patient population. There's been more transparency in the decision-making process. There's been more stakeholder involvement in the process, including the manufacturers. And there's been a movement in some countries towards what we call early engagement, where the manufacturers talk to the payers for health care at an early stage to understand the evidence requirements. Next slide, please. Now, what about changes in the decisions themselves? Now, there are different sorts of studies of that, descriptive studies, various kinds of econometric studies, and some qualitative studies. I'll just give some examples, including one that we did in the United Kingdom. Next slide, please. Okay, so I'm going to talk about one of the descriptive studies, which is one we did on NICE in the UK, the one by Mason and Drummond, but there are some other studies that have also compared different jurisdictions. Next slide, please. So this was our study. What we looked at was NICE's guidance on new cancer therapies, from the first one they looked at in May 2000 through till 2008, when we finished this study. And the idea of the study was to look at what the license indication for the drug was, and then what NICE had reimbursed the drug for. So trying to understand whether there was any restriction on how the drugs were being used through the payment mechanism as opposed to the license for the drug. Next slide, please. So these are our headline results, and what you can see that in more than half of the cases, NICE approved the drug for payment as per the license. So there was no restriction at all. So NICE was quite happy in more than half the cases to pay for the drug at the price that the company wanted. However, you can see that in about 15% of the cases, NICE said, well, we don't think this drug should be used at all, we're not going to pay for it. And then in about 30% of the cases, it was restricted in some way, usually restricted to a subpopulation of the overall patient population for which the drug had a license. Next slide, please. And what's quite interesting is some of the reasons that they give. It's difficult sometimes to understand the reasons because in the reports that they often give multiple reasons, but trying to do the best thing we could see that these are the sorts of reasons. And the interesting thing here is that on the left-hand side you have what you might call the economic reasons, that the ISA, the incremental cost-effectiveness ratio is too high, or that was given as an explicit reason for restriction. So cost-effectiveness seemed to be important in those cases. But you can see that on the right-hand side you have other reasons, one of which is insufficient evidence of effectiveness. Now, all of these drugs had a license, so how could we say there was insufficient clinical evidence? Well, the reason is that sometimes the payers want to see different kinds of evidence than the regulator. And that's something which the companies have gradually learned through time, that they have to develop evidence to satisfy both the person making the reimbursement decision as well as the person making the licensing decision. Next slide, please. This is just the study that compared the Canadians with the Australians with the English, and you can see, I think the fourth bullet there, that NICE was approving about 85% of the drugs, which is consistent with what we found in our study. Next slide, please. There have also been qualitative studies which have looked at studying how the committees have worked and the kinds of factors that the committee felt was important in making the decision, and typically cost effectiveness comes second in importance after clinical effectiveness, and that's probably not surprising. Next slide, please. So the final issue, because I'm almost out of time, is, well, has it really made any difference to the provision of healthcare more generally. Now, there are some problems here because it's difficult to specify what in research we would call the counterfactual. What this means is, what would have been the situation in the United Kingdom if we hadn't have had a NICE in 1999? So, because we never saw what would happen without a NICE, it's hard to know what would have happened in practice if we'd have never had NICE. Also, the question of what we should pay for a new technology is unknown or uncertain for most jurisdictions. And some jurisdictions, well indeed most, do not have adequate mechanisms for enforcing adherence to some of these decisions. And of course, we often don't know what we would have foregone in the healthcare system by agreeing to follow the guidance by NICE. Perhaps there are other more important things that should have been done beyond the ones that NICE recommended. Next slide, please. And some of the critics, and I must say I'm not included in these, but this is the alternative point of view. We call this the nightmare counterfactual. This is saying, what's the bad things that have happened because of NICE? Well, these people argue, first of all, that the decision-making threshold of cost-effectiveness has been set at the wrong level, probably too high, these people argue. Therefore, the manufacturers just price up to the threshold, whereas otherwise their prices would have been even lower. And then also the fact that you give attention to these expensive medications means that they get more of a consideration that they would have gotten if we didn't have a NICE. Well, I personally don't agree with that. Next slide, please. Because I think if there is evidence on pricing, it often, certainly I know from the NICE case, that manufacturers have often had to revise their price expectations downwards rather than upwards. And really the biggest payback, I think, from the economic analysis has been to more effectively target these expensive therapies to the patients that would have the greatest benefit. And if you don't have those sorts of policies, you're going to be under more pressure, both from the general public and from the medical community, to make every new technology available. Next slide, please. So, in conclusion, I would say that there is now substantial evidence that cost-effectiveness has become an important decision-making criterion in the countries that have adopted this approach. I think consideration of the economic issues has highlighted uncertainties in the clinical data. Although part of the impact has been to refuse listing for some drugs, I think the main impact has been to restrict reimbursement to patient groups based on cost effectiveness, thereby increasing value for money that way. And depending on the local situation, price reductions have been secured, although I don't think that's the main part of it. I think if I was asked to justify the policy, it would be that by targeting our resources to the patients who would benefit the most is probably the best way of getting value for money rather than movements on price, although there have been some of those. So I'll finish there. Sorry I've gone on a little bit too long. Thank you.